This is Matthew McCoyd, and we're going to go into the third section of neurology for the internist as we work our way through the disorders of the nervous system that you would be expected to know for your examination. In this section, we're going to cover movement disorders, and specifically Parkinson's, and then move into disorders of the peripheral nervous system, including motor neuron disorders, peripheral demyelinating disorders, and neuropathies. For Parkinsonism, a 72-year-old male with a history of diabetes and asthma presents for a hand tremor and gait problems. Symptoms have been slowly progressive for at least several months, if not longer. His diabetes has been well controlled. His examination is notable for minimal facial movements, intact vertical eye movements, a resting hand tremor that's also notable as he walks, cogwheel rigidity, and a slow gait. Which of the following medications would be the most likely to improve symptoms? Levetiracetam, primidone, levodopa-carbidopa, amantadine, or dalfampridine. This patient has features very classic for Parkinsonism, and of the available options, levodopa-carbidopa is considered typically a first-line therapy for Parkinson's disease. Levodopa-carbidopa is the best available option for patients with Parkinson's disease. Levetiracetam is not indicated for Parkinsonism or tremor. Primidone is not used for Parkinsonism, but can be used for tremor. Amantadine can be used for tremor, but is not considered a first-line treatment option for Parkinson's disease. Dalfampridine is indicated to improve walking speed in multiple sclerosis. Parkinson's disease, the clinical features are the trap. Patients will have typically a rest tremor, cogwheel rigidity on examination, akinesia or bradykinesia, slowness of movements, and postural instability. About 90% of patients develop a rest tremor. 50% can also have it with arms outstretched. In my experience, you typically pick up that rest tremor during the history as the patient's sitting in the exam chair or as they're walking down the hall away from you, distracted, and you'll see the tremor come out. Secondary symptoms of Parkinson's can include a decreased arm swing, a decreased blink rate and masked facies, hypophonia, difficulty turning over in bed, also difficulty turning during the examination. Non-motor features of Parkinsonism include a REM sleep disorder in which patients will act out their dreams. Constipation and anosmia are probably early signs of Parkinson's, though not specific. This is a clinical diagnosis. There is an available objective test called a DAT scan, which can help confirm the diagnosis, but it's a clinical diagnosis, so testing is not required. In terms of treatment, carbidopa-levodopa can be helpful for the akinesia and rigidity. Dopamine agonists can also be used in a carbidopa-levodopa sparing strategy. And for severe tremor, deep brain stimulators are an option. Contrast that with this case, a 72-year-old male with a history of diabetes and asthma presents for hand tremor. Symptoms have been present for some time. His diabetes has been well controlled. Examination is notable for normal facial movements, intact vertical eye movements, bilateral action-induced hand tremor, and a normal gait. He states it's hard to eat and drink because of the tremor. Which of the following medications would be most likely to improve symptoms? Levetiracetam, primidone, levodopa-carbidopa, amantadine, or dalfampridine. This individual has no evidence of Parkinsonism, but has an action-induced bilateral hand tremor. So the best available option that's listed is primidone. This patient has features of benign essential tremor, for which primidone is indicated. Levetiracetam is not approved for tremor. Amantadine has been used for Parkinson's-related tremor, but is not approved for benign essential tremor. Levodopa-carbidopa is not approved and would not seem to be helpful for this tremor, and dalfampridine is only approved for multiple sclerosis-related walking. Essential tremor, the characteristic clinical feature is an action-induced tremor. It's oftentimes slightly asymmetric. The tremor can also involve the head and the neck. Patients oftentimes turn their head in either a yes or a no type of motion. There can be a tremor of the jaw and oftentimes a voice tremor. When asked, patients will oftentimes report a strong family history. Patients typically will say it bothers them the most when they're trying to eat or drink. As they reach out to grab something, their hand will shake. As they try to drink or eat, their hand will shake. This diagnosis is also a clinical diagnosis, mostly based off of the history and exclusion of Parkinson's disease. A DAT scan can be helpful. DAT scans in essential tremor are normal, versus in Parkinson's, they show decreased dopamine uptake in the basal ganglia. But it's a clinical diagnosis, so testing is not required. In terms of treatment, beta blockers, and specifically propranolol, are commonly used, which was not listed as an option here. What would make it a more challenging question is including medical conditions that would contraindicate the use of a beta blocker. So asthma is a relative contraindication to the use of beta blockers, as could the diabetes. Primidone is considered an equivalent therapy for benign essential tremor. It's equal in terms of efficacy and would be considered of the available options the best choice. For severe and refractory tremors, deep brain stimulation is also an option. Moving on to disorders of the peripheral nervous system. So we said at the beginning of the lecture that in neurology, conditions can be divided into central or peripheral nervous system disorders. In my experience, symptoms tend to involve one system or the other. The peripheral nervous system, even for neurologists, is oftentimes intimidating. The central nervous system, the brain, the spinal cord are relatively easy. You can localize it to the best of your ability, and typically you're going to get an MRI scan that will confirm your diagnosis, or maybe some other objective testing like an EEG. The peripheral nervous system does not lend itself as well to imaging, so you're much more dependent on a history, a physical examination, and some testing. But for all of its complexity, there are only three parts of the peripheral nervous system. There's nerve, neuromuscular junction, and muscle, and that's it. And of the peripheral nervous system disorders, they tend to affect one of these three and only one of the three. So as a neurologist, once I've decided, yes, it's neurologic, yes, I think it's in the peripheral nervous system, my next step is this a nerve problem, a problem with the interface, the neuromuscular junction, or a problem with the muscle? And once I can localize to those, I'm farther along my differential. For disorders of the nerve, there's an almost limitless number of things that will cause neuropathy, right? And an almost limitless number of tests you can order to try to confirm the cause of a neuropathy. Despite the countless number of things that can be on the differential, if a patient has a neuropathy or a problem with the nerve, there are only 4 pathologic responses to nerve injury. You can damage the neuron. There's a motor neuron and a sensory neuron. So you can damage the nerve cell body. Motor neuronopathies are common, like ALS. Sensory neuronopathies are rare, even within neurology, and I'm not going to cover them. I can damage the neuron. I can damage the myelin, the protective coating of the nerve, which is produced by Schwann cells in the periphery versus oligodendrocytes in the central nervous system. I can damage the protective coating, which will slow the signal from point A to point B. These can either be acquired or hereditary. I can damage the wire itself, and these are your classic neuropathies. This is what most people think of when they think of neuropathies. I've got numbness and tingling in my feet that slowly works its way back over the course of months to years. And typically from conditions like diabetes or B12 deficiencies. And the last group of neuropathies are really the mononeuropathies. What happens when I compress a nerve for a long period of time? Right? If I damage a single nerve, what's my end result? So that last group is really the kind of focal compression, which is your mononeuropathies or potentially your plexopathies or radiculopathies would fit in this section. So if a patient has peripheral nervous system disorder, and I think if the issue's in the nerve, it's going to affect one of these 4. It's going to be a neuronopathy, demyelinating, axonal, or that individual nerve injury.